Good morning, everybody. This is Dr. Sumit Banerjee. Am I audible to everyone? Kindly please answer in chat as one if you can hear me and if the presentation is visible. All right, great. So we'll start our presentation now. So I'm going to be talking about compartment syndrome and workman ischemic contracture. So what we attempt to learn from the end of this session is what is a compartment syndrome and to identify underlying pathology and the main causes of compartment syndrome. We'll explain the principles of patient assessment. We'll identify the relevant investigations and what is the practitioner's role in the sense that when do we need to critically decide about the management, right? And we'll also talk about what are the options for conservative and surgical management options and the care of the patient. Lastly, we'll talk about what is Workman's ischemic contracture and its pathophysiology and classification. So compartment syndrome in a sense is an elevation of the interstitial pressure in a closed osteofascial compartment that results in macrovascular compromise. What this essentially means is that there is a closed compartment, and if you fill too much fluid into it, it starts to expand and it starts to put pressure on the wall. Now, since the osteo here means bone and fascia is obviously fascia, both of them are relatively non-flexible. So what happens is that it doesn't expand beyond a certain point, and then the pressure starts to build up. So what happens when the pressure starts to build up? The collapsible things start to collapse, which is, in this case, the vessels. So once the vessels are compressed, the blood supply to that area stops, and that results in myonecrosis, muscle necrosis, edema, ischemia, and further damage. So that, in essence, is what compartment syndrome is. So, in other words, it is a condition in which the circulation and function of tissues within a closed space are compromised by an increased pressure within that space. Hope that is clear. If yes, can please write one and then we can move on further. So compartment syndrome was originally described by Workman in 1872, right? With reference to the forearm. So this is the forearm where it was discovered the most. Okay. So now we'll talk a little bit about the anatomy in the sense that why is it a closed space. So as you can see, this is an expanded diagram of a muscle fiber. So as you can see, all the individual muscle fibers are surrounded by a layer called the endomysium. Then the group in itself, slow.
You have opened it separately.
No, I was asked and they have said yes, they can see me. Just guys, can you see my presentation? If yes, say one. If not, say two. Okay. Okay.
You have two presentations?
No, just one.
Just one.
Just this one.
Display one selected. Display one. सर जो पीपीटी प्रेजेंट कर रहा है
प्रेजेंट नॉट किया हुआ है, बच्चों को दिख भी रहा है. Guys, just hold on for 1 second. There's some technical issue. I'll just continue with the presentation in a couple of minutes.
this one.
Yes. Right click पर.
PPT is not correct.
Right click. वही करना है ना slide show. Hit up. Second. Apply. Okay. एक बार इसको मैक्सिमाइज कर दीजिए.
फिर मिडिल स्मेल होता है that doesn't slide right ये my phone my phone मैं करता हूँ पूछ लीजिए
ये कैमरा ऑफ का तो इशू नहीं है Right, so we'll start again, okay, and continue from where we had left. As we're talking about, the individual muscle fiber or the cell is covered by an endomysium. Then this bundle is again wrapped in perimysium, and finally you have the epimysium. So you have a multiple levels of fascial sheaths that enclose the cell. And that in turn means that there are very small compartments in which the blood is flowing through. So as if there is an increase in pressure in any of the compartments, they start to necrose. So where are the key compartment syndrome sites? They are the lower limb compartments, followed by the forearm compartments, and then you have thigh compartments. It is more common in the lower limb and the forearm. Can anyone type me why that should be? Am I audible to everyone? Okay, yeah, good. Not really due to blood pooling. The point is that there are two bones in these, both in the forearm and in the legs. There are two bones, and in between the bones, there is a fascial membrane, right? The interosseous membrane. So, which effectively creates a big barrier, right? And it's a very non-expandable cavity kind of a structure, a decent barrier. So that's why you have a lot of fixed compartments already built into the system. So if you look at this anatomy of the cut section of the calf muscle, you can see that these are the two bones and these are the fascial membranes. Right? And these in effect makes it one compartment, two compartment, three and four compartments. So you have essentially four compartments, right? And that's why these are very small compartments, and any increase in blood pressure or the interstitial pressure leads to compartment syndrome very easily. So the normal intercompartment pressure is near about 0 to 8 millimeters of mercury. So now we come to the fact whether it's acute or can it be chronic itself. So a large percentage of compartment syndrome is actually acute, right? This happens any traumatic events, commonly fractures, with worsening symptoms and irreversible tissue damage within hours. So it's one of those few orthopedic emergencies actually. Chronic, on the other hand, is a recurrent syndrome. This happens because of repetitive micro trauma within the compartment. Small. This is essentially more due to overexertion. It happens mostly in athletes like marathon runners or for that matter bodybuilders, right? Because they're repeatedly giving micro trauma to their muscles, right? If they get adequate rest between the two episodes of exercises, it usually resolves. But if they tend to, especially this happens before events and competitions when they are trying to exert themselves too much, and then you can have symptoms of a chronic compartment syndrome. So causes, the first is an intrinsic cause, which is essentially a bleeding disorder. If there is a bleeding disorder, there will be continuous bleeding within the compartment, and then it will lead to increasing pressure. Post ischemic swelling, right? Rhabdomyolysis is essentially the degenerative enzymatic degradation of the muscle. Then you come to the extrinsic causes, and the biggest one, of course, is trauma, fractures. Then you have crush injury, right? Again, that essentially leads to a lot of loss of vascular supply into it, loss of endothelium, and lot of bleeding within the compartments. Then surgical procedures, right? If you give a division into it and then close it too tightly, that can also lead to a closure of the compartment and increased pressure into them. Then you have surgical positioning. If a limb, or let's say, has been positioned too much in a compressive syndrome, or the tunicate has been on for a long time, then can also lead to compartment syndrome. Constrictions, tight cast, compression bandages. These are one of the very common causes of compartment syndrome, especially when patients come from the periphery, where they've been treated by other quacks or untrained people who tend to apply really tight bandages to stop a bleeding or to hold the limb in position. In those cases, again, this can happen. Snake venom is another cause, right? Especially the snakes that have that injure the vascular compartment. Insect stings, again, they cause edema into the compartment because of the inflammatory reactions, and that can also lead to compartment syndrome. Burns, again, circumferential burns can reduce the flexibility of the skin and the compartment for it to expand, and it also causes a lot of edema inside the affected area. So that can also lead to compartment syndrome. IV drug use again. Exercise, as we talked about in terms of chronic exercises like marathon runners and bodybuilders, if they do not give adequate rest between the two exercise sessions, the muscle group can itself get overworked and can lead to edema inside, microvascular trauma, microtrauma, and further subsequent compartment syndrome. So what is the pathophysiology? How the cycle works? The fluid starts entering into a volume compartment, which causes the tissue and the venous pressure to rise. As the interstitial pressure rises, it exceeds the arterial venous perfusion gradient, which is essentially the difference between the arterial and the venous pressure, so that the blood can flow from the artery towards the veins and perfuse the area. So once that is breached, the blood flow stops, the capillaries collapse, and the muscle and tissue ischemia occurs. This now leads to necrotic products and lot of inflammatory products. These, again, in terms of fluid, further increase the pressure in the compartment, and thus a terrible cycle continues, right? So when they see, if you can see, these are the muscle compartments, and when they are pressing onto this part of their fascia, these are the blood vessels. So these tend to get compressed. So once the intercompartmental pressure, remember we had talked about that the normal is about 8, right? So if it goes up to about 30, that is the time when you really need to be thinking about operating, right? And if it goes beyond 40, it's a surgical emergency, and you have to relieve the compartment, otherwise you will lose the limb, right? More than the exact value, it is the amount of pressure gradient is more important. Right? So now we come to the assessment. So whenever you're assessing something, the first thing, as they all say, is that the eye only sees what the brain knows. So you have to always be aware that such a pathology can happen in high energy trauma, right? Always, any fracture, road accident, especially where a tire has gone over or they've been trapped inside or it has been taken in, from the history you get that the patient was trapped in the vehicle and had to be extracted after a while. These are the scenarios that should straight away raise an alarm that yes, he's been trapped, the limb has been trapped. There is a very high possibility that he could have compartment syndrome, right? The next and possibly the most important point is excessive pain in relation to injury, right? What are the 5 P's that we have studied? If anyone could type it into me. Yes, very good, very good. So it's essentially, yeah, stop. Right, that's good. Pain, pallor, pulselessness, paresthesia, and paralysis. So of this, the only thing that is really important to us is pain, right? So in any orthopedic injury, for that matter, it's a fracture or anything, once you've given a slight analgesia and immobilize the limb in a splint, the pain more or less settles down. If it is still not settling down, if the patient is still screaming in pain, something is wrong. And that should be your first and the most crucial warning. Pain, pain, pain. Those are the 3. If you have waited till pulselessness and paresthesia set in, you've already lost the limb, right? So excessive pain in relation to injury, even after splinting, if the patient is in pain, that should alert you that something's wrong and it could be compartment syndrome. Pain on passive stretching, that is another very specific finding to the compartment syndrome. What happens is that the compartment is already tight and stretched out to its maximum because of the pressure inside. If you further stretch it, there is just no way it can stretch any further and it causes excessive pain, right? That is again a very good indicator that there is something wrong with the compartment and that the pressure is very high, right? So pain on passive stretching is very important when you are assessing the compartment syndrome. Obviously, there will be swelling of the limb, and it will be tight swelling, not just any swelling. Even most fractures tend to get swelling, right? But swelling along with tight compartments should alert you towards a compartment syndrome. Finally, of course, you can measure the compartmental pressure. You've got special manometers to assess that, right? Once you do that, you realize if it's going beyond 30, then you're looking at a compartment syndrome. More important is the difference between the diastolic pressure and the compartment pressure, because it is only in diastole that the muscles will be perfused, right? So if your interstitial pressure is approaching the diastolic pressure, that means the chances of perfusion are going down. The blood will only flow from higher to lower gradient, right? So if both the gradients are coming together or close to each other, then the blood flow will be decreased. So that's another indication that you need to go in. As we had talked about earlier as well, don't wait for pulselessness or paresthesia, because if you are waiting till then, you've lost it. So the 3 P's in relation to compartment syndrome are pain, pain, and pain on passive stretch. Right? How do you diagnose? So assessment, the attending or the treating doctor is liable, is criminally or legally liable for this. And if you do not fail to do that, then it's a professional accountability. It's an act of omission and negligence is considered. So what are the investigation you need to do? You need to get an X-ray for the fractures, intercompartmental pressure. You can use a Vick manometer or a simple needle manometer, slit catheter. There are lots of gadgets available which can help you measure it. But more important, these gadgets, even if they're not there or you're not trained to use them, is your clinical, right? If you realize at any point that your pressure, you feel that there is excessive pain, the compartments or the leg or the limb appears to be tight and swollen, that is the time when you decide that yes, this could be a compartment syndrome and start treating accordingly. Conservative management, the first thing first, let's say the limb has already come in a plaster or a splint. The first thing is remove or split the splint to allow any external pressure being relieved. Elevate the limb, right? That helps with the gradient. Give him some analgesia and monitor him regularly. If that tends to settle the patient down, great, that's good. If not, then we'll proceed to the next stage. The next stage is essentially fasciotomy. That is essentially a surgical incision opening up of the fascia. Now, the question arises, what if we do not have the measuring devices and the situation is a touch and go? We are not quite sure whether it's a compartment syndrome, but we cannot be sure that it is not a compartment syndrome. In this case, it is always beneficial to give a benefit of doubt and go in for a fasciotomy. What is the maximum that can happen is that you've given a scar, right? And you have operated and opened the fascia, although it was still normal. No harm done. You can always close the wound. All he will be left with it is probably a little scar. That is much better than the other prospect of you not operating and it turning out to be compartment syndrome and the patient losing a limb, right? So in case of doubt in a compartment syndrome, always tend to err towards the operator side. So 2 incision, this is a very good guideline by the British Orthopedic Association, and it's called the BOST guideline. This shows how to approach a fasciotomy. So these are the 2 bones, the tibia and the fibula, and these are the 3 tense compartments. So there are 4 compartments here, one in orange, the pink, the red, and the blue. So as you approach, your first incision is towards here, right? You go in and release these two compartments. The second incision is towards here, and through which you release these two compartments. So essentially, two incisions and all your four compartments have been released, right? And when you talk about incision, we are not talking about skin deep incision. You have to go up to the fascia, split the fascia, put your finger or a spreader inside and make sure that the pressure is released. So this is essentially what a fasciotomy wound would look like. This is the posterior medial incision going all the way up to the foot. Right, this is how it looks like, the two incisions, and this has been closed in a crisscross fashion because of the pressure. As you can see, once they have given the incision, there is so much of swelling that you can't even approximate the wound. That's all right. Over a period of days, as we start to re-look at the wound, we can gradually, as the pressure subsides, the swelling subsides, we can gradually approximate the sutures, or if it is still left, you can do other methods of closure. Now we come to the forearm. Again, two incision, the dorsum incision and the volar incision. So this is the the volar incision through which you enter and release your flexor group of compartments, and this is to release the extensor group of compartments. Again, as you can see, this is a zigzag incision opening up the entire compartment, and again you have closed it over suction drains and umbilical tapes through which you can tighten them gradually and approximate them further. Now, if even after the compartment syndrome has subsided and you're still not able to approximate the wound, you can always cover it up with a skin graft. So follow up, continue to monitor it, check the wound at 72 hours. If at that point it has started to subside, then you can gradually go towards closure, approximation of the wound, suture removal at 10 to 14 days. If, however, it does not happen, then you might need to do in a skin grafting. So complications. What are all the complications that can happen of a compartment syndrome? First thing, obviously, what is getting compressed? If the nerve is getting compressed, it could lead to motor deficits like foot drop or the workman contracture. Infections, again, because there's a lot of fluid being accumulated inside, and it can lead to infection and potential amputation. Hyperesthesia, painful dysesthesia. This is again because of the nerve dysfunction, right? That can help with medications like phenytoin or carbamazepine or gabapentin. Recurrent. This is due to fibrosis, especially in athletes. As we talked about the chronic compartment syndrome, the muscles tend to heal with fibrosis and scarring, and this can lead to further or subsequent compartment syndrome. And finally, because of all the ischemic products being released into the system, it can result in acute renal failure, sepsis, or you can even throw out an emboli, and that can cause the adult respiratory distress syndrome. There are some psychosocial considerations as well of the compartment syndrome. If the limb is not working properly, the work and transport becomes an issue. So someone has asked me, do we cover it to prevent infection? So essentially what you do is you are treating it in the cover of antibiotics, and you will never completely cover it, because if you've covered it again, you have again created a closed compartment. So you just put in crisscross sutures, right? So just to keep it approximated, and these sutures can be pulled at, they are like shoelaces, right? It's essentially a shoelace kind of a closure. So as the swelling subsides, you can gradually just give it a little pull and start to approximate it further, and it closes up over a period of time. The optimal incision length, again, you have to open the entire compartment, right? So most of the time it is the bigger, the better. The optimal incision length is the length that allows you to open all the compartment throughout the length of the bone, right? So usually you end up so you end up opening the entire limb. There is a worry about infection, and you will always do it under the cover of antibiotics. But infection is a slightly delayed complication. You are more worried at this point about the acute ischemia. Ischemia would let you to lose the limb earlier than infection actually does it, right? So you will treat it under the cover of the antibiotics, keep the wound clean and dry. That's obviously part of it. But you don't close it because you don't want to close it, create a new compartment. So coming back to the psychosocial considerations, social activities are hampered if the limb is not functional. Relationships can be affected because of the disfiguration, because of loss of limb. Clothing, again, what kind of clothes you can wear, that gets affected. Holidays where you can go about. Body image, that's a very big concern. Cosmetics is lost, right? And this can all lead to a loss of self-esteem or work, right? So that is about the compartment syndrome. So the important, if I were to summarize about compartment syndrome, is be very alert to assess it. Pain and pain on passive stretching. Always look for it. If you find tight swollen compartments, err on the side of fasciotomy. When you're doing fasciotomy, make sure you release all the compartments, right? And gradually let it all subside, and then you can either close it or put in a graft. It happens mostly in between when there are two bones with intraosseous membrane is there, because then it becomes a tight compartment. Right. Now we move on to Volkmann ischemic contracture. It's essentially a sequelae of compartment syndrome, kind if you can look at it. So it's a end result of prolonged ischemia associated with irreversible tissue necrosis. So essentially what has happened is there was a compartment syndrome and you've not treated it, or he has presented late, and this has already set in. So it has got a broad clinical spectrum based on what amount of muscle has been damaged, what amount of nerve has been injured, right? Where exactly which compartment was involved, right? Since the muscle and the nerves are already dead or damaged, they do not have pain, but deformity and loss of function. Those are the characteristics of Volkmann ischemic contracture. Again, the same pathology. It's an ischemic event which leads to the damage to the nerve. The nerve dysfunction can lead to contractures. On the other hand, the second limb of it, there is muscle scarring, muscle death, and which is replaced by fibrosis. Again, that decreases the contractility and functions of the limb. They lead to joint deformity and eventually contractures. So essentially, dysfunction, contracture, and deformity are the hallmarks of Volkmann ischemic contracture. So causes, again, this is very common with pehlwans and traditional bone setter quacks. They will tight a bandage with all sorts of potions and balms and everything, and put in patas and sticks and all sorts. And then they are tightened and said, okay, now keep it on for 2 weeks, come back to me after 2 weeks and all will be well. No one bothers. The patient is crying because of pain, and it's like, okay, it's a fracture, it will always be painful, and it's never reviewed till it's too late. By the time it's reviewed, you've already lost the limb. So now we'll try and classify it, right? So the first type, this is a Such classification. It's a very widely known classification in use. It depends on what group of muscles has gone damaged and what is the consequent functional loss and how you manage it. So the first is a mild localized Volkmann contracture. So this is Volkmann contracture have been usually described in relation to the forearm, right? It usually tends to happen there. That's what is a specific name for. So it usually involves the deep flexure compartment, the flexure digitorum profundus muscle. Usually most common is the ring and the middle long fingers. These are the ones that are most commonly and the most initial ones to be affected. There is no nerve involvement here. So since only the muscle has been involved, you can stretch it out, splint it, right? And it is maintained all throughout to ensure that the other muscles are able to function. However, if still there is no function in those few compartments or the muscles that are involved, you can go for lengthening of it. You can fractionally lengthen them to regain the length and function of those flexure group. So as you can see, this area, the shaded area, this is the only area that has been affected right next to the compartment, right next to the tight compartment. So this is the area that has gone damaged. And this is what they present with. You can see the contracture of the flexors of the middle finger and the ring finger, right? This is what happens. And once you try to straighten it out, the wrist drops because of the contracture. He cannot extend both his wrist and the fingers at the same time. That's because there is contracture of that muscle group. The second is the moderate. In this, all of the flexure digitorum profundus and flexure pollicis longus is involved. Some amount of the FDS or the superficial muscle is also involved. There is nerve impression there. This is a slightly higher version. It's more in median nerve is more important because again it is in the center of that compartment. The median nerve is always in the center of the flexor compartment, so it tends to get damaged a lot more than the ulnar nerve, which is probably to one side, right? Surgical treatment is again you would go and fractionally lengthen them. You can shorten the forearm to allow for the length. Proximal row carpectomy is one of the versions of this. And again, as you can see, almost the entire flexor compartment has been involved. The FDS, the polyflexor pollicis longus, and some part of the FDS is also involved here. As you can see, there's a big, more amount of clawing. All the fingers are involved, and you cannot passively stretch it out as well. Finally, is the severe form, in which the entire flexor compartment is involved. Along with it, some amount of extensor compartment is also involved. Severe neurological deficits, including both sensory deficits, motor deficit, and intrinsic dysfunction, right? This almost always requires a surgical treatment wherein you have a tendon transfer or free muscle transfer, and sometimes even both may need to be performed alongside flexor slides and release of the contracture. You also sometimes need to do a nerve graft or a reconstruction. Again, as you can see, the entire flexor compartment is involved. Alongside, the extensor compartment is also getting involved to a certain extent. Right? This is the clinical image. You can see the severity of the contracture and also intrinsic dysfunction. If you can see, the small muscles of the wrist and the hand are also compromised here. Right? Is that clear? Any doubts, any questions about this at this point of time? Okay. Now we move on. I will try and summarize this, that the Volkswagen ischemic contraction per se cannot be prevented. It's already happened. You can only manage it and try and reduce the deformity and get back as much function as possible. What you can, however, do is avoid getting into such a situation, right? And that's where the cast care, the care of the cast or a bandage is very important. So I'll show you a video which talks about how the cast, how can you can take care of the cast. Hopefully it plays. No, it's not. Right. So I'll talk you through it. So essentially, whenever you're applying a cast or a splint, the key important things are you need to tell to the patient that whenever you're applying a cast or a splint, the distal part has to be left open so that the fingernails or the toenails can be visualized. And you have to keep an eye on it that it does not become too red or too white, which essentially means that both the arterial and the venous circulation is proper. Second thing, it should not feel too tight. He should not get any tingling sensations over the area distal to the cast. Once you've applied a cast or a splint, it is always a good practice to ask the patient to come back to you in 24 hours time. That is when you review, when the cast is set, the patient has slept on it, and if there is to be any other further swelling, you can notice it at that very point. Third things, whenever you are asking someone to apply a splint, always ask the splinted area to be kept on an elevation, right? This will aid in the sort of gravity will aid into the flow of the blood down and reduce the edema. Fourth thing, always ask them to move the distal parts. So if it's a forearm splint or a cast, you always ask them to do active finger movement. Similarly, if it's a lower limb cast, you always ask them to do active toe movement. This has two functions. First, the rhythmic contraction prevents the venous pooling of the blood and the blood is pumped back. Secondly, it also allows the muscles to continuously function, and any delay in that is good, can be a very good sign. Also, it will also give you an indication if there is any pain on stretching, right? So it's a very good warning sign. Avoid getting it wet or damaged. Don't try to stick things down your plaster to itch, because that can get stuck or could cause injury inside, right? Those are the few of the points that you need to be looking at when you're trying to advise about cast or splint care, right? These points, again, if I were to summarize, make sure that the distal Vasculature is intact and the finger is pink, not too red or white. Secondly, no tingling or paresthesia. Ask them to keep the limb elevated. Do active distal movements, active toe or active finger movement, as the case may be. Do not get it wet or damaged or try sticking things underneath them. Keep it elevated while you're sleeping. And most importantly, whenever you apply a cast or a splint, ask them to come back the next day in a 24 hours for review and advise them at any point if they feel that it's getting uncomfortable, it's too painful, or the limb is feeling paresthetic, or you feel that the tips of the fingers or the toes are going white or red, contact the emergency ASAP. As soon as possible, they should come to the emergency. And the first thing you need to do is probably spread the cast and let it be. Right? Any further questions? So that's essentially all about our class today, right? This is essentially this final image is a good way of how to take care of the cast. It's elevated, the patient is smiling, he is comfortable, all his distal fingers are visible. So that makes a good sense and a great case for how to care for the cast. Any questions? Or we can wind up the class now. So someone's asked me that why VIC mainly occurs in children. So not necessarily, it can occur in everyone. The point is in kids, they tend to realize the pain a lot later. The signs can often be missed in children. So that's why you end up having that more commonly in children because it's diagnosed a lot later. And also because the point is by the time the contractures are more in kids, that is because the rest of the skeletal system is still growing. So the muscle progressively shortens over a period of time. Whereas in adults, it's already grown. So whatever death happens, it does not lead to that much of deformity. So we can say in a way that it happens in everyone, but the deformities and the dysfunction is more pronounced in children because of the growing skeleton. Okay. All right. Yes, I will try and share the PowerPoint to you guys. Thank you very much. So this is where we'll end the class. Thank you. Thank you very much.
Microphone on. मैं दिख रहा हूँ कि नहीं? Chat पे 83 more बता दिया जाए. Yes, and can you listen to me? Just type out, can you listen to me? That's good. Okay, so good morning, all of you. So what I will be doing is, I will be giving you some gift. And you know what's the most precious gift as students? Teachers are supposed to love their students. And what's the most precious gift I can give to you is, as you know, is your time. Okay, so I will give you time. You just spend hardly 20-30 minutes. It's a 10 o'clock to noon, 12 o'clock slot. I will just take your 20-30 minutes. Thereafter, you have your time, which you can enjoy whatever you want to do, right? So in this, I will be sharing two videos. So I will start with the first video, then we will come back again. So just chat, just write on chat that are you ready for the next? Shall I start the video sharing? Okay, good. Okay, before that, I forgot to ask you one question. One question only, one question is, you can just reply on chat. You want me to eat your 2 hours or just 30 minutes? So for those who go for 30 minutes, just write 30. Yeah, that's good, that's good. Satvik is first one reply. Yeah, that's fine, that's fine, that's fine. That's fine, that's fine, that's fine. Starting, yeah, I'm starting. Okay. Just finding how to share this screen of, yeah, present now. A window and window. Okay. Okay, I just want to confirm, just chat once. Could you see the video with audio? Okay, okay. So now I will start it, and after the video finishes, it's hardly 10-15 minutes video, we will again talk a little bit. Very little, I promise. चल रहा है चलता रहेगा अपने वीडियो अगर कुछ होगा तो है ना हाँ कर दिया मुझे पूछ भी क्या चला गया वीडियो दिख रहा है ना अभी टाइप करूँगा तो देख सकते हैं ये टाइप कर दूँ अगर 3 केस अटक गया तो मुझे बता देना क्या हुआ अच्छा यहाँ पे लिखती हूँ तो कि भाई अगर बन गया तो बता देना ना
Jarvis, come online. Good morning, doctor. I got a link from your resident. Waiting for permission to open. Go on. 48-year-old male presented 1 month back with focal seizures progressing to secondary generalization. Associated with left-sided weakness. Now for the past week the episodes are repeating frequently and paralysis of left-sided upper and lower limbs has progressed. But peculiarly the patient seems to be unaware of his left-sided symptoms and seems to neglect left side of his body. He seems to ignore the left side of his visuospatial space. We have received radiological images of his brain. Waiting for confirmation to open. Opening MRI brain images. There is a heterogeneous space-occupying lesion right parietal lobe appearing hypo-intense in T1, while intermediate to hyper-intense in T2 sequence. Post-contrast images shows intense peripheral enhancement. It also shows areas of necrosis and hemorrhage within the lesion with vasogenic edema around the lesion involving cortex. Impression: malignant SOL in right parietal lobe. Emergency resident had informed us to take over the patient. Waiting for confirmation.
No, Jarvis. Send the patient to a neurosurgeon. Let them chop it off. Let's see.
Really? Rolling up the sleeves? Now. Excuse me, boss. You have a message.
Come on, open it.
Hi, doctor. New update on that patient. Patient underwent surgery successfully, near total resection of tumor with improvement in symptoms. Post-op histopathology report confirms glioblastoma WHO grade 4. Tumor cells are positive for GFAF with wild-type IDH mutation and Ki67 index is 80%. However, the symptoms have started to reappear. Waiting for your opinion.
Jarvis, it's time for us to take him to a medical oncologist. Let's see what they can do about it.
Blood vessels in the brain have specialized endothelial cells that are packed very tightly, forming junctions through which small molecules leave the blood and enter the brain tissue. The blood-brain barrier poses one of the major challenges for drug delivery to the brain, as it blocks almost 95% of drugs delivered orally or intravenously to treat neurological diseases.
Excuse me, boss. You have a text message.
Jarvis, come online.
Sorry to interrupt. It's an emergency. This is regarding the GBM patient we had kept on chemotherapy. Her current clinical assessment is suggestive of worsening signs and symptoms despite chemo. Projecting the radiological images to your smart glass. Imaging is suggestive of recurrent progressive sole at right frontoparietal lobe including basal ganglia. Also it involves corpus callosum, appearing to extend across body of callosum, to contralateral side. Associated with extensive edema.
What are our further options, Jarvis?
Running analysis. Error 404. Could not find any further treatment. We are losing the war doctor. The cancer cells are advancing beyond control. Any surgical intervention will worsen the neurological status and any more systemic chemo will destroy the normal tissue. Shall I break the bad news to the attendants?
Stand down, Jarvis. Bring me online. Assemble the team. Warm up the linear accelerator. Ready the sequential integrated boost plan. And shift the patient to treatment ISO center.
Where'd that come from?
It's nanotech. You like it?
Imagine this. You shine a flashlight at a tumor. You remember from high school physics that visible light is a type of radiation. So does that mean visible light can also treat cancer? Absolutely not, because it's just light. Continue reminiscing high school, and you'll remember that visible light is only one type of radiation on the electromagnetic spectrum. It is enough energy to give us light to read and see things, but not much more than that. X-rays and gamma rays are types of radiation with much higher energy on the spectrum. So much energy, in fact, that they can ionize atoms in their path. Ionization is when an atom loses a particle, most often an electron, and becomes charged. The ability to ionize atoms is important because it can disrupt biological molecules and potentially kill cells. This is the basics of how we use radiation to kill cancer cells. You may be wondering, how on earth do we produce this radiation? X-rays for cancer treatment are commonly generated by a linear accelerator. In this machine, high-speed particles, often electrons, collide with a metal target and photons are released. This photon beam can then be directed towards a patient and their tumor. Mechanism of action. How does radiation damage cancer cells? At At the cellular level, radiation can cause direct DNA damage or indirect DNA damage. Most of our current radiation techniques cause indirect DNA damage. This is when radiation contacts water around target cells to cause reactions that produce free radicals. Additional contact with nearby oxygen produces an even more toxic superoxide. These radicals in turn cause damage to the cell. Direct damage is less common. Heavier particles, like protons, rely on this form of damage. The goal of radiotherapy and other cancer treatments is to produce a double-strand break. This is when both strands of polynucleotides are broken in the same spot. This should understandably be harder for cancer cells to repair. Enough accumulation of these double-strand breaks will hopefully lead to cell death. It is easiest to cause a double-strand break when a cell is in its M phase of the cell cycle. This is when the chromosome is dividing. Cancer cells divide more often than normal cells. That is, their cell cycles repeat more frequently. This makes cancer cells more vulnerable to radiation than normal cells. Keep in mind, a tumor will contain thousands of cancer cells. If we gave a one-time giant dose of radiation, not every cell would be in its M phase, and therefore not equally affected. To distribute damage, we break up the total dose of radiation into smaller amounts given over multiple days. This is called fractionation. This increases the chance of radiation catching a cell in its M phase and causing adequate DNA damage. You may be wondering what is happening to normal cells in the middle of all of this. Not surprisingly, normal cells are affected by radiation too, and they may also be in their M phase, leading to possible double-strand breaks. Radiation therapy and other cancer treatments hinge on the principle that normal cells heal these defects better than cancer cells. Fractionation also allows normal cells to recover in between treatment fractions.
This is a CT simulator machine. Before delivering the radiation, we take CT scans of the tumor and involved region to delineate the volume in which the radiation is to be delivered. This is the CT console. The CT images will be captured in these computers and shared to the treatment planning system. In the TPS, the images are visualized and the tumor is contoured and volume and dose are defined. The images after contouring will look like as given. Now this machine is called the linear accelerator or the LINAC. This machine is used to deliver high energy radiation to the tumor tissue. Here you can see the 360-degree rotating gantry and the treatment couch.
Right on the ground. I can close it. Can anybody copy? I can shut the portal down.
Do it! No, wait. Stark, these things are still coming. I got a nuke coming in. It's gonna blow in less than a minute. Close it.
When the place comes to read me the last sight, take a look to the bowels of the last sight. I'm a wall that has gone very wrong to me.
the rain of the sun, so the rare, wants to stop the surmounting terror. Is it really the end? That's a crazy dream. Somebody please come down and dreaming. Somebody to stop from screaming. The voice is me, and I'm trying to speak. Okay, now. Am I visible? Huh? Am I visible? Neglect, yes. Okay. Okay. Just type V if I am visible. Huh? V. Okay. ठीक है ना? Okay. So you will have some questions. I am not going to listen to them. Okay. So why I am not going to listen to them, I will tell you. We can talk a lot when you come back to the institute later on. But at the same time, you can be resourceful. You can read on your own, learn on your own. There are some questions like, should you mug up some classifications, the vocabulary, the name of the drugs? Sometimes for marks, some people do. Sometimes it is required for some competitive exams. But as far as learning is concerned, let me again gift you, I gifted you just time, okay? Just 10 minutes more and you're free. So I will give you not my own advice, right? How to learn this will be part of this first lecture, and I will again share you a small video clip, which I like very much, right? So I will share you wisdom from two great teachers, right? So are you ready for one small next video so that can guide how you have to read and learn? Okay, so I will just sharing this second video.
Feynman is in the forefront of one of the oldest and most intriguing games of hide-and-seek in science, finding the ultimate constituents of the world. In this search, Feynman is a celebrated maverick who was encouraged by his father, a New York clothing salesman, to confront conventional wisdom.
One Sunday, all the kids were all walking in little parties with their fathers in the woods. And the next Monday, we were playing in a field. And the kid said to me, "Say, what's that bird? What's the name of it? Do you know the name of that bird?" I says, "I have the slightest idea." He said, "Well, it's a brown-throated thrush." He says, "Your father doesn't teach you anything." But my father had already taught me about the names of birds. Once we walked and he says, "That's a brown-throated thrush." He says, "Know what the name of that bird is? A brown-throated thrush." In German, it's called a Flügelflügel. In Chinese, it's called a Qilong. In Japanese, a Tahara, and so on. And when you know all the names in every language of that bird, you know nothing, but absolutely nothing about the bird. Then we would go on and talk about the pecking and the feathers. So I had learned already that names don't constitute knowledge. Into knowing the name of something. That's caused me a certain trouble since, because I refuse to learn the name of anything. So when someone comes in and says, "You got any explanation for the Fitz-Clonan experiment?" I says, what's that?" He says, "You know, they take uplift K meso and disintegrates into 2 pies. Oh, yes, no, I know. But I never know the names of things. What he forgot to tell me was that knowing the names of things is useful if you want to talk to somebody else. So you tell them what you're talking about.
But the basic principle of knowing about something rather than just knowing its name is something that you stuck to, isn't it?
Yes, of course. We have to learn. These are kind of disciplines in the field of science that you have to learn. To know when you know and when you don't know, and what it is you know and what it is you don't know. And it's you got to be very careful not to confuse yourself.
We should know how to handle, not only how to handle the success, how to handle the failures. Particularly you are in the management environment, I want the young people to understand how to manage the failure. Because any task you do, you have to come across problem. Problem should not become the captain of the individual or the project chief. The project chief should become the captain of the problems and defeat the problem and succeed. Learning gives creativity. Creativity leads to thinking. Thinking provides knowledge. Knowledge makes you great. History has proven that those who dare to imagine the impossible are the ones who break all the human limitations. In every field of human endeavor, whether science, medicine, sports, arts or technology, the names of the people who imagined the impossible are engraved in our history. By breaking the limits of their imagination, they change the world. You take C.V. Raman, you take Newton, you take Einstein, you take Chandrasekhar. By breaking the limits of their imagination, they change the world. If you want to be discoverers, if you want to be innovators, I am going to give you what type of characteristic you must have. Invention and discoveries have emanated from creative minds that have been constantly working and imagining the outcome. The telephone, he was imagining the outcome in the mind. With imagining and constant effort, all the forces of the universe work for that inspired mind, thereby leading to invention and discoveries.
Sir, I would like to hear from you a few tips for the upcoming generation to succeed in life.
Well, succeed in life, I have already told you.
Yes, sir.
You have to do 4 things, okay? Number 1, great aim.
Great aim.
I will have great aim.
I will have great aim.
I will
continuously
acquire knowledge.
Continuously acquire knowledge.
Oh, I will do hard work.
I will do hard work.
I will persevere.
I will persevere.
And succeed.
And succeed.
Okay, that's the mantra.
Thank you, sir. Thank you so much.
You have many accomplishments. You've written books. You've served as president. You're an aerospace engineer. You've been a professor. But you say the title you like best is the title of teacher. Why is that?
You know, I had a teacher when I was a young boy, 10 years boy. Wartime, the Second World War going on. At that time, I used to see in my class, 5th class teacher, in science teacher, he entered the classroom. And we used to see the radiation of knowledge from him. When he enters the classroom, my teacher, I see a radiation of purity of life. And the way he taught, my dream got shaped. What should be my way of life? He is the person, the teacher gave me the vision of my life when I was a young fellow. Now, teacher has got the fantastic opportunity to grow minds, to enrich the minds, and to give the dreams to the young people, and to nurture the dreams with them, and they will become a great human being. Sometime they will become better than you, but better than the teacher. So that opportunity you have. I will have great aim. I will continuously acquire knowledge. How I will do hard work. I will persevere and succeed.